When we talk about treatment in the newly diagnosed myeloma patients, the exact combination of medications depends a little bit on where you are in the world, but usually it's a combination of 3 or 4 medications, depending on your age and your other comorbidities. If you're eligible, we'll consider deepening that response with a stem cell transplant. That's an autologous stem cell transplant, which is different than what we use in myeloma or in leukemia. We use your own stem cells. And that's followed usually by maintenance therapy or long-term therapy. When we're looking at this part, the combination of 3 to 4 medications up front is often called induction therapy. It's not traditional chemotherapy, but they're often targeted agents, which are a combination of an antibody therapy, an immunomodulatory agent, a proteasome inhibitor, and a steroid. So we often use those 4 medications together for 4 to 6, even more potentially months, to induce a response, to get the myeloma tumor burden down. And then we consider deepening that response with something called a stem cell transplant. And this is usually good at sort of increasing the depth of response, meaning getting rid of additional residual disease to prolong the time that a patient's in remission. Now, this is an intense high-dose chemotherapy, which is followed by a dose of the patient's own stem cells. Again, this is an autologous stem cell transplant. Because it's a high-dose chemotherapy, there are a lot of side effects associated with it. Patients are in the hospital. They have severe fatigue and GI side effects, and they have low cell counts, putting them at risk of infections. And so to go through the stem cell transplant, patients must be fit. And each transplant center will have slightly different criteria of who is fit for transplant. And so sometimes ultimately the decision is that a transplant might cause more harm than benefit, but that's a discussion that we're often having with our patients around stem cell transplant. After transplant, or even if the transplant doesn't happen, if a patient is ultimately elects not to go forward with the transplant, then we go to maintenance therapy, which we consider the long-term therapy. It's usually a combination of an antibody treatment with a pill. The optimal duration is unknown. Right now, we're often treating patients until progression or until they can't tolerate the therapy anymore. But we're getting more data on exactly what the correct or optimal duration for any individual patient might be.